Good morning to one and all. So, my topic today is atypical Meniere's disease. So, I'm going to present a case and share my experience of atypical Meniere's with you. So, atypical Meniere's is when you don't have the entire complement of symptoms of a definite Meniere's. So, you have some but not all the symptoms of a definite Meniere's. So, that is when it is called atypical Meniere's. And during the evolution from atypical Meniere's to a definite Meniere's, there will be various pathological states. So, depending on the pathological state in which the patient is seen, you can either have a cochlear Meniere's presentation or a vestibular Meniere's presentation. So, I am going to present my case. So, she was a 50-year-old lady and she was a ENT surgeon herself. She presented with severe giddiness that was there for about 2 days. She was also complaining of a ringing sensation and blocked feeling in the right ear along with the giddiness. So, I'll go into more details. You will see that when I present this case, especially the chief complaints and the presenting illness will be looking more like a definite Meniere's disease. But what is interesting is when we go into her past history, the details will reveal that what it had come to the present, it had actually evolved over a period of time. So, I'll be going into the details soon. So, presenting illness, she had true vertigo and it had lasted for about 2 days. So, she had 2 episodes in 2 days and each episode lasted for about an hour. And she also had autonomic symptoms like nausea, vomiting and a sensation of bowel movement along with the giddiness. And after about an hour it subsided. After about a bout of vomiting it subsided. And she also told me that she had this ear block and tinnitus in the right ear when she had this vertigo. All this was about a month back when she presented to me. So, I also questioned her about the other symptoms like loss of consciousness, the other routine negative history which you would like to rule out in an acute vestibular presentation. And very important, I asked about history of migraine headache, she denied. And I also questioned her about the cerebellar symptoms. So, past history, she didn't have a history of similar attacks in the past, no comorbidities. And a year back, she elaborated when I questioned her about her ear complaints. So, a year back is when it all started according to her. So, she had traveled to a hill station and then while descending down, she developed a right ear tinnitus. So, she assumed it is due to some eustachian tube dysfunction. She also said she had some sound sensitivity, something like recruitment during that time. So, being a ENT surgeon herself, she had not presented to me at that particular time. So, she was a ENT surgeon herself. So, she thought it is due to eustachian tube dysfunction. She took some decongestants and antihistamines. She waited. About 3 to 4 days later, the tinnitus did not subside much. When she tried to have a conversation over the phone, she noticed that right side she hears less. So, she got a little concerned and she did her audiometry. So, audiometry, she found that she had a right-sided moderate sensory neural hearing loss. So, she wanted to be extra cautious. She also, because she thought it is a right side sudden hearing loss, that is what came to her mind. She thought it's a right-sided sudden hearing loss. So, she did other tests. She did a HRCT and a glycerol test also at that time. The glycerol test came out positive. So, that was one important finding at that point of time. The temporal bone study was normal. She didn't undergo a MRI. She did a temporal bone study. It came out as normal. So, after that, because she thought it is a sudden hearing loss, she took a course of oral steroids, proper 15-day course. And she also, because it's her hearing, she wanted to be she wanted to over-treat it, and she intratympanic treatment as well with dexamethasone. So, she waited, the tinnitus did not improve, but her ear blocked sensation, the hearing became a little better. I don't have the audiogram of her sudden hearing loss when she had it, but I have a post steroid treatment audiogram with me. This was her audiogram 1 month after she took the steroid treatment. And sorry. So after this hearing loss treatment following the hearing loss, she feels I told you she felt better, and her tinnitus did not improve. 2 months after this episode, she happens to drive over a flyover, and she feels uncomfortable. She couldn't narrate that the vertigo which she had at that time. She felt it is more of an imbalance. It was not true vertigo according to her. For 2 minutes she felt very uncomfortable. She stopped driving. Then she rested for a while. It became better. She didn't have any change in the tinnitus, is what she told me at that time. And after 2 minutes it got better and she drove back home. So after following that episode, she felt a little uncomfortable, like whenever she used to walk, some kind of imbalance which she couldn't be very clear about. She started herself on Vertin, 8 milligram BD, and she continued that. She became better. So after about 1.5-2 months, she stopped the treatment. This was all in 2008, last year. And whatever complaints that I narrated to you was this year, about a month back. So at this point, if we analyze, look into the details of the past history, what had started as a sudden hearing loss has actually progressed to a definite menias disease. So people with atypical menias can have either a cochlear or a vestibular presentation, and they can evolve into a definite menias disease. So this is what I try to narrate in my past history. When she came to me, that is like 2 days after the acute attack which she had. So I did a routine examination. In that, the positive findings was the nystagmus which I could elicit with the on removing the fixation. I could see a spontaneous nystagmus beating towards the right. So it was to the same side of the menias probably. Probably it was a irritative nystagmus at that time. The other symptoms, cerebellar signs and all that was negative. I ruled out BPPV. And the head impulse test, when I did the head impulse test, I could demonstrate the catch-up saccades to the right side. So these were the tests that I ordered. And the audiogram, you can see that, don't know if you can see the pointer. So this is the audiogram when she came to me. You can see the right side, low frequency hearing loss, moderate to severe hearing loss, and you would see that you can see another graph above it. So this graph is the audiogram which was taken after the dehydration testing. So I did dehydration testing with glycerol. I used about 1.5 gram per kg body weight, and 3 hours after she was given glycerol, this was the audiogram at that time, the red line, that is the post-glycerol audiogram. So I felt glycerol test is a sensitive test, especially in the early stages. 66% of patients can have a positive test, especially when you have atypical presentations. This test is helpful, and there are studies which have actually done the documentation on this. And in patients with diabetes and hypertension, where you feel glycerol is not suitable, you can give furosemide. So this was the dehydration test. And another test which I did was the WEMP test. WEMP test also showed some abnormal thresholds. Studies have shown that even post dehydration, the WEMP test can demonstrate an improvement. I haven't done that in this patient. And on doing a cold caloric test, it was hypoactive on the right side. That was the cold caloric finding. As I told you, the OAE and WEMP test, OAE autoacoustic emissions and WEMP test also can show improvement after the dehydration testing, according to studies. I treated her with lifestyle modifications, which she had already adopted earlier. And I told her that if she develops symptoms of tension vascular headache or migraine, she should get treated for it. Already, she told me that she doesn't have migraine, but I told her about it. And I started her on hydrochlorothiazide, 25 milligram OD, and Vertin 8 milligram BD was given. And I told her during the acute episodes alone, she can have vestibular suppressants. A few things about atypical menias. I wanted to share this particular chart with you because these are the various pathological states. I told you about the vestibular and the cochlear menias. So before going into definite menias, when they have vestibular, they can have a recurrent episodic vertigo. They can be present with or without the hearing loss. In cochlear menias, they can have a fluctuating hearing loss, and again the vertigo can be in the form of unsteadiness, or it can be without vertigo, or they can have only one episode of vertigo. So these are some interesting articles I came across on atypical menias, and they tell that in cochlear menias, the progression to definitive menias is much more than in a vestibular menias. This is what the studies say. And in cochlear menias, even a single vertigo episode is more in favor of it will show more progression, and you can be more sure that the patient is expected to go into a definite menias soon. And ECOG, which I did not do in this patient, I don't have experience with ECOG, but they say electrocochleography, dehydration testing, and the three-dimensional MRI with the gadolinium contrasts. There is a specific sequence for doing it. It is a fluid attenuated inversion recovery MRI. So that can demonstrate the endolymphatic eye drops in atypical menias cases. So this is what the studies are telling. But I haven't tried this electrocochleography and gadolinium enhanced MRI. I've spoken to the radiologist at my place, and he has agreed to do this for me. So probably I will get more insights on this over the next few years. So conclusion, it is important to consider functional testing in atypical cases, and if at all the patient is giving a history of migraine, it's important that we treat it. Keep the patients under follow-up, because it's important to notice what kind of symptoms they develop over a period of time. And we need to look into further studies, especially with the MRI. Not many experiences are shared, so further studies are needed. I thank you all for your patient listening, and I thank Cyclops team for giving me this opportunity to talk about this. Thank you.